Screen is visible, ma'am.
Yeah, fine. So, okay. So today we will be talking on the subject of polycystic ovary syndrome. I have given the title for this as a new look at the old subject. So this is because since 1935, when Steen and Leventhal first described this syndrome, there have been many hypotheses and also studies that looked into the etiology and also the pathogenesis of this complex disease process that pans throughout the life of a woman. So it is in 2018 that we have got this international guidelines for the screening, diagnosis, assessment, and also management of polycystic ovarian syndrome that has made a sort of cleared the air for the management of this complex disease process. So on this note, we would go to the presentation. So in this presentation, I would sort of let you understand what are the underpinnings for the development of polycystic ovarian syndrome, appreciate the metabolic burden, and become familiarized with the common management approaches for improving the health of these women suffering with polycystic ovarian syndrome, and also to gain insight into the options available for the individualized management of women with polycystic ovary syndrome. So polycystic ovary syndrome, it affects nearly 5 to 20% of the reproductive age women. It is a heterogeneous condition. It may present with reproductive, endocrine, metabolic, and psychosocial symptoms. Most importantly, PCOS remains underdiagnosed many times with significant delay to the diagnosis. It is a complex disorder which has a high impact on the quality of life, and hence it requires a timely diagnosis, timely screening for all the complications, and also timely management of all the clinical borders that appear in the spectrum of this disease. So what we need to understand here is that we are still in the learning process of understanding the underpinnings for the development of this entity called polycystic ovarian syndrome. So we do realize that this issue usually stems in utero, in the early pediatric life or in the adolescence, and usually it progresses to the adulthood. There are many underpinnings have been hypothesized, but there is less data to tell that PCOS is a genetic disorder. So there have been many studies that have come up saying that multiple genes are involved or predisposed to the development of polycystic ovarian syndrome, but there is no single gene that pans across and all that says that this is a particular gene that results in polycystic ovarian syndrome. So there are animal models which have led us to a clear understanding of polycystic ovarian syndrome, and now it appears that in utero exposure to androgens, be it iatrogenic androgens, such as in animal models, or be it exposure to maternal androgens in babies of women with polycystic ovarian syndrome, or in women with high androgens, having high androgens like in luteum of pregnancy, for example. The fetal in utero exposure or fetal exposure to high androgens also sets the stage. So there are many genetic, epigenetic, and also environmental underpinnings that have been hypothesized for the development of polycystic ovarian syndrome. There is maternal obesity, and also the presence of gestational diabetes has also been given priority for the development of PCOS in women in their childhood. So by optimizing the maternal health, the maternal obesity, and also by controlling the gestational diabetes, can we reduce the burden of this disease early in the childhood? So, but there are many hypotheses. There is no substantial evidence as of now that by improving the maternal health, we can improve the well-being of the child. So baby girls who are born for gestational age, they have a rapid weight gain. They tend to have a rapid weight gain and also a rapid catch-up growth. And these are the population that are at risk for the development of childhood obesity. And these populations should be addressed. And this is the population that needs to be addressed, because these people going into the future, they may develop polycystic ovarian syndrome like features in their adolescence. So these population may develop premature adrenarche, they may develop premature pubarche, and also early onset of puberty. And they may have these polycystic ovarian syndrome like features when they go into the adolescent group. So more and more focus has been done in the previous couple of decades on visceral adiposity and also childhood obesity, which can also be which are also indicated to be factors for the development of PCOS as they progress into the adolescence. So physiological insulin resistance is usually a norm when the child enters into the pubertal growth phase. So insulin resistance is usually a part and parcel of the pubertal milieu that is present. So, but what happens here is when a child is having insulin resistance in the peripubertal period, and if the child sets into puberty, so the insulin resistance which is there, in the insulin resistance which is present, it may have a different action, and this may cause a dysfunction of the hypothalamo-pituitary ovarian axis and also help in increasing the androgen excess from the adrenals and also the ovarian and also from the ovaries. So what I mean to say is whenever there is an insulin resistance in women with in children who are in the peripubertal period, there is an exaggerated risk of developing hyperandrogenemia in the adolescence. So, we are talking about the maternal influences. We are talking about the genetic and also the epigenetic environmental influences. We are talking about maternal obesity. We are talking about visceral adiposity. We are talking about childhood obesity, all factors which culminate into the development of a syndrome called as polycystic ovarian syndrome. So what happens here is whenever there is a hyperandrogenism and also insulin resistance, there is a phenotype that sets in. So whenever this phenotype sets in, where is this female going to in the adulthood? So where is this female heading to in the adulthood? In the adulthood, this female is not only having just the clinical concerns or the clinical borders of having menstrual dysfunction or having androgen excess symptomatology, but she is also having a potential for subfertility, and also there may be and also most importantly, there may be development of metabolic dysfunction leading to exaggerated exposure to the prevalence of type 2 diabetes and also cardiovascular dysfunction, and there may also be a psychosomatic dysfunction. So these are the cascade of events that lead to the development of PCOS even from in utero to the adulthood. So it is very important that we intervene very early in this disease, maybe in the adolescent period. If we can intervene, we can impact and also improve the quality of life of these women. So coming to the hypothesis that is developed for the pathophysiology of polycystic ovarian syndrome, there is a two-hit hypothesis which has been developed, as I have told you earlier. So because of the in utero exposure to maternal androgens, because of small for gestational age, and also there is a catch-up growth, there is childhood obesity. So all of them, because of this obesity, there is development of increased androgen production and also increased insulin resistance. So all of these are adding up to the increased androgen production from the adrenals and also from the ovary. And also the insulin resistance, which is revving up the androgen production from the adrenals and also the ovary. So once there is this phenotype that sets in, that androgen is, there is increased androgen production and also there is increased insulin resistance. So this high insulin resistance and also this high androgen milieu, so they cause a dysfunction of the hypothalamo-pituitary ovarian axis, causing alteration in the GnRH signaling mechanism, so which causes an increase in the LH predominant phase and also a disruption of the secretion of FSH, which is more important for the follicular development and also for a normal ovarian function. So this increased androgen production, disrupting the GnRH signaling, increased LH secretion, and also causes increased androgen production. It causes disruption of the follicular dynamics and disruption of the menstrual and causing menstrual abnormalities. There is ovulatory dysfunction, and also there is an abnormal estrogen and also progesterone milieu which is present, which adds up to the androgen production again. So there is a cascade of events which set up here. So androgen production is, so there is a high androgen production which is begetting the high androgen production. So whenever there is an increase in the high androgen production, there is disruption of the hypothalamo-pituitary gonadal axis, alteration in the GnRH signaling mechanism. There is an increase in the LH, there is a decrease in the FSH, or there is a disruption of the FSH. So there is a decrease in the follicular dynamics. So leading to all the cascade of symptoms, and the estrogen and also the progesterone milieu which is present, again it increases the androgen production, and also the insulin resistance which comes from obesity, physical inactivity, and also poor diet also adds into the androgen production. So when the ball gets rolling, there is a vicious cycle that is formed. So what we can do is, if we can abort this cycle at a stage where there is where we can abort the insulin resistance which is increasing the androgen production, so we can improve the quality of life of these individuals. That is why, because there is obesity, physical inactivity, and poor diet which is leading to insulin resistance, these patients need lifestyle intervention at the earliest. So how does ovarian follicular maturation arrest happen in PCOS? Because there is an increase in the androgens, there is an increase in the LH, predominant LH environment is there, LH along with insulin sensitizing growth factor 1. It causes again increase in the androgens. These androgens, they cause a decrease in the FSH, because FSH is responsible for the follicular recruitment. Because there is no FSH, there is no recruitment of the follicles. So these follicles get usually arrested in the preantral and also the early antral phase, and all the follicles, the late antral and the pre-ovulatory follicles, they turn into the cystic follicles, which appears as polycystic ovarian morphology on ultrasound. So because they are arrested at the preantral and also the early antral follicle levels, there is an increased secretion of AMH from the granulosa cells of both the preantral and also the early antral follicles. And hence, it explains why there is an increase in the AMH in patients with polycystic ovarian syndrome. And here, with all the insulin resistance and also the hyperandrogenism, there are certain symptoms which can be seen in patients with polycystic ovarian syndrome, such as acne, hirsutism, and also acanthosis nigricans in the uterus, because there is an increased estrogen production. There is endometrial hyperplasia, and also because there is ovulatory dysfunction, there is anovulation, and also amenorrhea. So what are the diagnostic criteria for diagnosing PCOS? So there have been many diagnostic criteria which have been proposed as early as in 1990. The NIH or the NICHD criteria have been proposed, according to which a woman can be labeled as having polycystic ovarian syndrome when she demonstrates both of these criteria. Either she can have a clinical hyperandrogenism, which manifests in the form of acne and or hirsutism and or thinning of the hair. and or she can exhibit biochemical hyperandrogenism, which is usually manifested in the form of elevated testosterone levels, be it either total testosterone or free testosterone levels. And also there is, in 1/3 of the patients, there is an increase in the adrenal androgens, that is DHEAS is also elevated. And the second criteria is oligoovulation, which is manifested in the form of menstrual disturbances like oligomenorrhea or amenorrhea. So this criteria requires the presence of hyperandrogenism, either clinical or biochemical, and also the presence of menstrual abnormality. In 2003, we have a more robust criteria which has come up, that is the Rotterdam criteria. So according to this criteria, for the patient to be diagnosed or to be labeled as a PCOS, should demonstrate two of these criteria. Either she should have oligo or an ovulation, which is in the form of menstrual disturbances. Either she can have oligomenorrhea or amenorrhea. And also she should exhibit clinical hyperandrogenism and or biochemical hyperandrogenism. A very important feature for the Rotterdam criteria is the presence of a classical appearance of ovaries on the ultrasound, which is known as the polycystic ovarian morphology. So according to the Rotterdam criteria, the polycystic ovarian morphology, to fit into the polycystic ovarian morphology, by using a transvaginal ultrasound, there should be more than 12 follicles between 2 to 9 mm, and also the ovarian volume should be more than 10 ml. So this is the criteria that can be met for the polycystic ovarian morphology. So for a patient to be designated or to be labeled as polycystic ovarian syndrome, they can have either menstrual disturbances and polycystic ovarian morphology with or without hyperandrogenism. So Rotterdam criteria has allowed us to diagnose a more heterogeneous population, but it has also allowed us that maybe some normal patients also we may be labeling them as having polycystic ovarian syndrome. And in 2006, this Androgen Access Society have come up with a new guideline, and according to this, a patient to be labeled as having PCOS should demonstrate both. Either she should have a clinical and or biochemical signs of hyperandrogenism, or she should have oligoovulation or polycystic ovaries. So they have understood that ovulatory dysfunction may manifest either in the form of menstrual disturbances or in the form of polycystic ovaries. So Androgen Access Society criteria, it requires the presence of both hyperandrogenism or polycystic ovaries or menstrual disturbances. So, but all these criteria are met when only the other exclusion criteria for the differential diagnosis of PCOS have been excluded. So that include hypothyroidism, such as hyperprolactinemia, such as late onset congenital adrenal hyperplasia, and such as androgen secreting tumors, and also such as iatrogenic that giving exogenous gonadotropins. So after the exclusion of all these criteria, the patient can be labeled, and if she has any of the criteria following these guidelines, then she can be diagnosed as polycystic ovarian syndrome. So the International Evidence-Based Guidelines for the Management of Polycystic Ovarian Syndrome, which has given in 2018, they state that using endovaginal ultrasound transducers, which are around 8 megahertz, they have increased the threshold of the follicle number from 12, which was originally given by the Rotterdam criteria, to greater than 20 follicles and ovarian volume of greater than 10 ml, ensuring no corpora lutea, cis or dominant follicles are present. So they have changed the diagnosis by putting up more number of follicles into this guideline. So they have also given clear protocols that are recommended for reporting follicle number while doing an ultrasound for polycystic ovarian syndrome patients. So what are the recommended minimum reporting standards? You should report the last menstrual period. You should also state the transducer bandwidth frequency and also the approach or the route assessed. That is whether you're doing an abdominal scan or whether you're doing a transvaginal ultrasound. And also you should mention the total follicle number, which is measuring between 2 to 9 mm. And also it is important that you measure 3 dimensions and also the volume of each ovary. So by taking into all these considerations, labeling the patient, identifying the polycystic ovarian morphology and labeling the patient as PCOS should be done. So we have our ultrasounds have been more advanced. Our ultrasound machines have become more advanced, and we have a 3D ultrasound these days, so which allows us for a better reproducibility when compared with the 2D methods. And the more important is that we have a Sono AVC, which is a semi-automatic method, and this program, it clearly counts all the follicles and also measures all the follicles, giving color coding to each and every follicle. So this has made our life easy, so that we are not missing any follicles. But it requires specific trained sonologists and also advanced ultrasound systems, which are more expensive. So because of this thought, many researchers have been doing a lot of studies as to whether antimullerian hormone can be used as an alternative for PCOM or polycystic ovarian morphology. So there are many studies that have been done, but what does the international guideline say is that serum AMH level should not be used as an alternative for the detection of polycystic ovarian morphology. So it does not give a clear indication to use AMH as an alternative to polycystic ovarian morphology. It is because there is an emerging evidence that with improved standardization of assays and establishing proper cutoff levels for AMH, only then we will be able to do a validation in the populations of different ages, and also AMH will become more accurate in the detection of polycystic ovarian morphology. So according to the international guideline, they have given certain steps for the diagnosis and also for labeling a patient as having polycystic ovarian syndrome. Step 1, if the patient is having irregular cycles and also she is exhibiting clinical hyperandrogenism, that is if she is having hirsutism or acne, by exclusion of other causes, we can come to a diagnosis of polycystic ovarian syndrome. But if the patient is not having clinical hyperandrogenism, so we have to take a clear history of the patient. If she is not having clinical hyperandrogenism, then do a test for biochemical hyperandrogenism. We can do a testosterone, either free or total testosterone, do a DHEAS. So whenever there is a biochemical hyperandrogenism, then the diagnosis is clear. The patient can be labeled as having polycystic ovarian syndrome. But if the patient is having only irregular cycles, she is having irregular cycles or hyperandrogenism, any of that is present, then it is recommended for adolescents. Ultrasound is not recommended. Ultrasound is not indicated because there is a bias whenever we are doing an ultrasound for adolescents. So we should be able to differentiate between a polycystic ovarian morphology picture and also a multicystic ovarian morphology picture. So, but in adults, we request an ultrasound for polycystic ovarian morphology. So if there are irregular cycles with the polycystic ovarian morphology, if there is hyperandrogenism with the polycystic ovarian morphology, then the patient can be diagnosed as having polycystic ovarian syndrome. So why is there an importance of diagnosing hyperandrogenism in patients with polycystic ovarian disease? It is necessary to make a diagnosis of PCOS first thing. And also second one, the most important thing is it identifies the phenotypes in PCOS. And also this feature is best associated with metabolic abnormalities. And most importantly, it serves as a prognostic factor for treatment success. So depending upon the clinical features which are present, there are 4 phenotypes of polycystic ovarian syndrome, which are represented as phenotype A, B, C, and D. So in phenotype A, all the 3 features are present, that is hyperandrogenism, ovulatory dysfunction, and also there is a polycystic ovarian morphology. In phenotype B, only hyperandrogenism and also ovulatory dysfunction is present. In phenotype C, there is no ovulatory dysfunction, but there is hyperandrogenism and polycystic ovarian morphology. In phenotype D, there is only ovulatory dysfunction and polycystic ovarian morphology. It is important for us to know these phenotypes because we can assess their response during our treatment. So what are the factors that predict live birth in patients with PCOS when we are giving or when we are giving them treatment for infertility? So younger age patients, usually patients who are of younger age, they have a better outcomes with our treatments than patients with an advanced age. Patients who are having a lower BMI usually respond better and have better outcomes than patients with a higher BMI. Shorter duration of infertility therapy. This is more important whenever we are taking infertility therapy for every patient, not only in polycystic ovarian syndrome, but it is very important that we decrease the time to pregnancy of patients coming for infertility treatments and offer them optimal treatments so that the time to pregnancy is reduced. And patients with less severe menstrual disturbances, they have a better outcome than patients who are having a severe menstrual disturbances. Patients with lower androgen level usually respond better and have better outcomes than patients with higher androgen levels. So whenever we are talking of the management of PCOS in the infertility population, so the first and foremost important thing is what is suggested is a lifestyle intervention. So why do we want to have a lifestyle intervention in patients with polycystic ovarian syndrome? As I have told you, obesity, physical inactivity, and also poor diet, mainly they are the underpinnings, or they lead to insulin resistance, which is indirectly leading to androgen production. So if there is an increase in the androgen production, so there is this cascade of events which is taking place, and also there is an increased LH and the ovarian follicular dynamics are disrupted, and there is infertility which is happening. So it is important for us to make the patients understand that lifestyle modifications not only improve their fertility status, but also improve their overall quality of life. So why do we need to take a lifestyle intervention or offer lifestyle intervention in our patients? So here there is a study here on the left-hand side. You can see that they have looked into the percentage of PCOS and also the BMI. So where they have seen that as the BMI increases, the percentage risk of PCOS also increases. So they have said that for every 1 unit increase in BMI, there is a 9% increased risk of developing polycystic ovarian syndrome. And here you can see whenever there is excess weight and polycystic ovarian syndrome, there is ovulatory dysfunction, there is increased insulin resistance, increased androgen activity, worsened psychological function. Most importantly, we have a reduced ART success. This is another study which looked into the body mass index and also the ongoing pregnancy rates for women with polycystic ovarian disease. So they have said that BMI more than 29 is usually associated with reduced success of ongoing pregnancy. And they have shown that with an increase in BMI per kg meter square, there is a 4% lowering of the pregnancy rate. So lifestyle intervention usually is followed as the first line therapy to improve the fertility, reproductive, and also the metabolic borders of the female. So whenever the patient is counsel the patients for having a healthy lifestyle, and also counsel the patients that at least 5 to 10% of the weight loss within 6 months may improve their ovulatory function. What are the guidelines which have been given in 2018? So they have given that the patient should be counseled regarding healthy lifestyle behaviors, which encompass healthy eating and also having regular physical activity to improve their quality of life. So these lifestyle interventions are recommended for patients to decrease the weight and also to decrease their central obesity, and also it decreases their insulin resistance. So guidelines for the dietary management. So they have counseled the patient regarding the advantages of a healthy, balanced diet, and also we need to help the patient in tailoring the dietary changes according to their food preferences, so that their diet is of a more sustainable thing rather than going for a crash diets. Regarding the exercise intervention, according to this guideline, they have recommended that at least 150 minutes per week of exercise, or at least 30 minutes per day of exercise would be enough for the patients with polycystic ovarian syndrome, so that it improves their quality of life and also gets down the insulin resistance. So first line of management after the lifestyle, which is a non-pharmacological management, would be a lifestyle intervention. But along with the lifestyle interventions, we need to go on with the pharmacological management also for these patients with infertility. So what is the international evidence-based guideline has suggested is that letrozole can be used as a first-line therapy for patients with PCOS. So clomiphene citrate can be used next, and clomiphene citrate with metformin can be used. Metformin can alone be used in patients sometimes, and then we can go on with the gonadotropins. If they are clomiphene resistant, or if the patient is not responding properly, then letrozole or clomiphene can be added with gonadotropins. The second line pharmacological management would be either use gonadotropins or go in for a laparoscopic ovarian surgery. And the third line management would be if all these treatments fail, the patient is not getting pregnant in spite of all these measures, third line management would be for going for ART procedures, that is IVF or ICSI. So what they have suggested is letrozole should be considered as the first line pharmacological management for ovulation induction, because it improves the ovulatory rates, the pregnancy, and also the live birth rates. So letrozole, it can be used alone or it can be used in combination with gonadotropins. To improve the pregnancy rates and also live birth rates. So how is letrozole used? The dosage is 2.5 to 5 milligrams per day is given starting from day 2 of the cycle for 5 days. On day 2, an ultrasound is done. So it's very important that whenever we are giving either oral ovulogins or gonadotropins, monitoring by ultrasound should be done. So after 5 days of gonadotropin, after 5 days of giving letrozole, then the patient is called either on the 11th or the 13th day, do an ultrasound. When the follicle reaches 18 to 20 mm, trigger is given. And then we have the other protocol, which is otherwise known as the extended letrozole protocol, where 2.5 milligrams of letrozole is started on day 1, and usually it is given for 10 days. So, and then an ultrasound is done, and when the lead follicle reaches 18 to 20 mm, trigger is given. We have a letrozole step-up protocol, which is most commonly used in patients with PCOS for a monofollicular development, where we give 1 tablet on day 2 of the cycle, then step up to 2 tablets, 3 tablets, and also 4 tablets, and then follow up with ultrasound, and when the lead follicle reaches 18 mm, give a trigger. So letrozole step-up protocol is most commonly used for patients with polycystic ovarian syndrome for monofollicular development. Clomiphene citrate is the next most commonly used drug, given in the dosage of 50 milligrams per day for 5 days. You can start it either on day 2, 3, 4, or 5 of the cycle and give it for 5 days. But the thing is that you need to monitor your cycles. Every time you give an oral ovulogens or gonadotropins, please try and monitor your cycle so that you are knowing exactly what the patient's response is. Because in PCOS patients, there are hyper responders, and a dose of as low as 50 milligrams also can cause a hyper response in these patients. So after giving clomiphene citrate for 5 days, do an ultrasound. When the lead follicle reaches either 20 or 22, you can give a trigger. So here, first we start a clomiphene citrate with 50 milligrams per day. In the first cycle, if there is ovulation, it's fine, continue with the same dose. Or if there is no ovulation, step up the dose to 100 milligrams per day in the second cycle. If there is ovulation, continue with the same dose. But if there is no ovulation, you can step it up to 150 milligrams per day. So with even 150 milligrams per day, if there is no ovulation in these patients, then clomiphene citrate can be added with injectable gonadotropins, which gives a good success rates. So what are the evidence-based guidelines say about clomiphene citrate? It can be used alone in women with PCOS and infertility, or it can be used in combination with metformin. There are many studies where they have compared clomiphene citrate versus clomiphene citrate plus metformin. So it has been shown that clomiphene citrate plus metformin gives a higher pregnancy rates and also improves ovulation and higher live birth rates when compared with clomiphene alone. So clomiphene citrate, that is what they under the the guidelines also say. So this can be used in patients with clomiphene citrate resistant. So what are the concerns about metformin? So whenever we are given metformin, so the main concern is the gastrointestinal side effects that comes with metformin. So these are the adverse effects that are usually dose dependent and self-limiting, but these are the main concerns for the patient. So patient may not be able to tolerate metformin sometimes. So the metformin is usually started using a low dose with 500 milligrams increments. Every week you increase it by 500 milligrams. When the patient is tolerating well, maybe 1500 or 2000 milligrams can be given to the patient. So to combat this adverse effects or the gastrointestinal side effects, and in patients who are not tolerating metformin, there is another alternative drug which has come up in the market these days, are the inositols. So these inositols are the nutraceutical products where till now the studies which have been conducted have shown no adverse effects. But the clinical research question is inositol alone or in combination with other therapies effective for the management of hormonal and clinical PCOS features and also weight in adolescents and adults with PCOS? So there is a lot of literature in the Cochrane Library and also the BGOG, and there are many studies. Which have come up and they have given treatment with inositol in anovulatory women with PCOS versus placebo or no treatment. And they have found out that when inositols are given in women with PCOS, they have achieved a significantly improved ovulation rate. There is increased frequency of the menstrual cycle. That is, menstrual cycles have become more regularized. Clinical pregnancy rate was evaluated in 2 trials, but they found no differences with inositol from placebo or metformin. But they have found that there is a significant decreased levels of total androgen, total free testosterone, DHEAS, and also the levels of SHBG, which are usually decreased when polycystic ovaries, significantly increased after treating with inositols. Also, inositols have caused a significant decrease in the fasting insulin levels, fasting glucose, the HOMA index, and insulin area under the curve. Okay, there are no serious adverse effects which have been reported with inositol till now. So how does myo-inositol has advantages when it is used in IVF treatments. So when myo-inositol is given, there are limited studies which can show all these things. But when myo-inositol is given in patients who are undergoing IVF, the gonadotropins that are required, the dosage of gonadotropins that is required is decreased, and also the number of days of stimulations also decreased, and the clinical pregnancy rates have a sort of little increased, but it is not so significantly increased. So there is a Cochrane library in which the antenatal dietary supplementation of myo-inositol has been given in women during pregnancy for the prevention of gestational diabetes. So when myo-inositol supplementation is given during pregnancy, the fasting insulin levels of these patients also decreased, and it has shown a little beneficial effect in giving inositol in these patients with gestational diabetes. The side effects, usually metformin has the gastrointestinal side effects, which are not usually seen with myo-inositol, which makes it more tolerant to the patient. And also, if at all its advantages are proved, maybe we can use it as an alternative to metformin. But what does the international evidence-based guideline say about the inositols? The inositol should currently be considered as an experimental therapy in PCOS. Because there is an emerging evidence, we need further research to get inositols into our practice. Regarding the gonadotropin treatment in patients with polycystic ovarian syndrome, so gonadotropins can be used as a second-line management for these patients. And also gonadotropins can be used along with clomiphene citrate, and also gonadotropins can be used along with letrozole. Letrozole plus gonadotropins versus clomiphene with gonadotropins. So in this, letrozole with gonadotropins has a higher pregnancy rates and also higher live birth rates. So gonadotropins could be considered as a first-line management. As the first line management only whenever the patient, only after explaining it to the patient, the risks and also the benefits. The potential risk of multiple pregnancy should be explained to the patient, and then only they can be offered as a first line treatment. So they can be offered whenever there is clomiphene resistance, and there are no other infertility factors to improve the ovulation, pregnancy, and also the live birth rates. Gonadotropins can be used in addition with metformin. So when metformin is given along with gonadotropins, there is a decrease in the gonadotropin dosage also, and it can be used in patients with clomiphene citrate resistance to improve ovulation and also the live birth rates. So gonadotropin therapy, whenever gonadotropin therapy is given, it is important for us to closely monitor the patient with ultrasound. So gonadotropin therapy provides better per cycle and cumulative pregnancy and live birth rates when compared to oral anti-estrogens. But there is need for intensive monitoring with ultrasound when using gonadotropins. And gonadotropins, usually in polycystic ovarian syndrome, can be given either in the form of a step-up protocol, a step-down protocol, or a chronic low-dose protocol, which usually we follow, which helps in the monofollicular development of these patients. Laparoscopic ovarian surgery, it could be considered as a second-line therapy for women with PCOS who are clomiphene resistant, who are having an ovulatory infertility, and with no other fertility factors. But when comparing between gonadotropins and also laparoscopic ovarian surgery, laparoscopic ovarian surgery should be offered in patients where after explaining the risks of the treatment and also weighing the benefits of these laparoscopic surgery over gonadotropins. So whenever we are attempting IVF in patients with polycystic ovarian syndrome, what are there are many peculiarities that we observe. So what are the peculiarities that we observe? We are going to see. So what is the goal of goal of IVF in patients with polycystic ovarian syndrome is having a pregnancy, but the priority in these patients is safety, because most of these patients are prone for developing ovarian hyperstimulation syndrome, which is the most complex complication. So here we can see a meta-analysis was done to see the outcomes in patients while doing conventional IVF in patients with polycystic ovarian syndrome. So here we can see in the first line, it is the number of oocytes per ovum pickup. No doubt, we know that we retrieve a lot number of oocytes in women with polycystic ovary syndromes, but when we see the number of oocytes fertilized, there are very less number of oocytes which are fertilized. This is because most of the oocytes which we get from the patients with polycystic ovarian syndrome, they may be immature oocytes. So what is the odds ratio for cycle cancellation? So that is a little less. And what are the chances of live birth rate and also chances of miscarriage per started cycle? So they have compared the PCO patients with the non-PCO patients, but the chances of live birth and also the chances of miscarriage, they are similar in both the PCO patients and as well as the non-PCO patients. So this is a study where they have looked into the cumulative live birth rates after IVF in a patient, where they have taken the phenotypes of these PCOS patients. It is a retrospective cohort study which was done in 567 patients from January 2010 to December 2015. And they have concluded that hyperandrogenic PCOS phenotypes, they confer significantly lower cumulative live birth rates compared with their normoandrogenic counterparts. So what is the importance of these findings? These findings may imply the need for adapted counseling and also tailored approaches when treating PCOS patients with hyperandrogenism who require ART. So it is very important for us during the diagnosis of PCOS to identify these phenotypes. So whenever a patient is having hyperandrogenism, so it is important for us to let them know that their outcome may be a little less when compared to the patients who are not having this hyperandrogenism. And here they have clearly shown that the phenotype which is having a hyperandrogenism, here PCOM, it is having ovulatory dysfunction and also hyperandrogenism, they are having a lesser cumulative live birth rates when compared with the phenotypes which are not having this hyperandrogenism. So the more severe the PCOS phenotype, the lower probability of cumulative live birth rates we have. So what is the influence of metabolic syndrome in women, in PCOS women undergoing in vitro fertilization? This was a secondary analysis of multicenter RCT. So they have compared the live birth rates after fresh and also frozen embryo transfer. So what are the conclusions they have drawn is women with polycystic ovarian syndrome who are having a metabolic syndrome, they have a negative impact on their female fertility, and also they have the adverse effect on in vitro fertilization cycles. That is, their outcome is less when compared with the patients who are not having metabolic syndrome. In vitro maturation is one thing which has been much hyped. It is the maturation in vitro of immature cumulus oocyte complexes collected from the antral follicles. In PCO patients, because of the risk of ovarian hyperstimulation, the PCO patient is stimulated, and maybe on the 5th or 6th day of the cycle, trigger is given and the immature oocytes are collected and they are matured in vitro to develop into an embryos, and then they are transferred in the subsequent cycle. So what are the clinical committee recommendations? In units with sufficient expertise, IVM could be offered to achieve pregnancy and live birth rates for patients who are undergoing IVF or ICSI treatment, where an embryo is generated, then it is vitrified and thawed, and it is transferred in the subsequent cycle. So whenever we are stimulating a patient of PCOS for IVF, So the most common protocol we follow is the Gonadotropin antagonist protocol, GnRH antagonist protocol. And the clinical committee or the evidence-based recommendations also say the same thing. So GnRH protocol should be preferred over the GnRH agonist protocol, because there is a high incidence of development of OHSs with an agonist protocol. So choice of FSH, whether we use a urinary or a recombinant FSH, it does not have any difference, but there is insufficient evidence to recommend specific follicle stimulating hormone preparations as of now. Use of exogenous luteinizing hormone treatment should not be routinely used in combination with FSH therapy in patients with polycystic ovarian syndrome. Adjunct metformin can be used in patients where we are giving them a GnRH agonist therapy, so that we can improve the clinical pregnancy rates and also decrease the risk of OHSs. So whenever we are going on with the GnRH agonist protocol with adjunct metformin therapy, so the clinical committee recommendations are metformin commencement should be at the start of the GnRH agonist treatment. It can be given in the dose between 1000 to 2500 milligrams daily, but metformin should be stopped at the time of pregnancy test, or if the patient, or if it is a failed cycle, of the patient has menses. And more importantly, the metformin side effects should be kept in mind. So while we are stimulating the patient of PCOS for IVF, trigger forms the final trigger is most important thing, that is that helps us to decide on the further management of the patient with PCOS. So whenever we are starting on with the GnRH antagonist protocol, start with the lower dose depending upon her antral follicle count, and also depending upon her AMH. Start with a lower dose, and maybe the dose can be stepped up. So whenever there is an anticipation that this patient may go into a hyperstimulation syndrome, then the patient is given a GnRH agonist, a freeze all, and they can be transferred in the next cycle. But if at all the patient, after giving the recombinant FSH, if the patient is not, if we don't anticipate that the patient might enter into ovarian hyperstimulation, low dose HCG can also be given to these patients. So what is the clinical committee practice is triggering final oocyte maturation with a GnRH agonist and freezing all suitable embryos could be considered in women with PCOS having IVF ICSI cycle with GnRH antagonist protocol. So we have we are in the era of using all individualized controlled ovarian stimulations, and there is a nomogram that have been developed by the Sesh Kamal Sunkara and also Antonio Lamarca, where they have identified the patients according to their ovarian reserve. Maybe they have seen the AMH and also the antral follicle count. So when the patient, usually the patients with PCOS, we term them as hyper responders because they are having a high AFC and also a high AMH. So what is the main objective in these patients is to minimize the ovarian hyperstimulation risk. And the main thing is use a GnRH antagonist protocol with minimal dose, start with the minimal dose and step up. And whenever there is an anticipation of hyperstimulation, give an agonist trigger and freeze all. So there has been a study, recent study, where they have looked into the live birth rates of patients with high responders. So they have seen that that's freeze only increase the chance of pregnancy in high responders. Yes, the freeze all definitely increases the chances of live birth. Well, what we can say is the cumulative live birth rates. Cumulative live birth rates are a sum of the fresh and also the frozen embryo transfers that we make. So in most of the PCO patients where we are anticipating ovarian hyperstimulation, we freeze the we do a freeze all and transfer them in the subsequent cycle. So whenever we do that, we are increasing the cumulative live birth rates. And also there are many theories that increase in the number of oocytes, there is an increase in the cumulative live birth rates. And also by increasing these cumulative live birth rates, we can decrease the time to pregnancy for these patients with PCOS. So what are the conclusions? It is a complex disorder with a complex etiology, insulin resistance, and also hyperandrogenemia. They play an important role in the pathogenesis. Early diagnosis is the key in addressing the symptoms, improving the quality of life, and also identifying the fertility problems. There should be a patient-centered approach with individualization of all our management strategies. Lifestyle intervention should be given to the patient, not only treating all her clinical bothers, but also counseling should be given to improve their quality of life. And because these patients are high responders, freeze-all improves the cumulative live birth rates. And most importantly, the patients with PCOS should be counseled regarding the long-term complications, and also the management strategies should be given for these patients according to their clinical bothers. Thank you.
Thank you so much, ma'am, for a wonderful talk. I think it was, as usual, it was very comprehensive and definitely a very, very fresh new perspective on PCOS. Thank you so much. Next, I will move to my presentation. I promise not to bore you guys. Probably I will just do a short presentation for 15 minutes on what is this new theory of gut dysbiosis all about. So I'm just sharing my screen. Ma'am, am I audible?
Yeah, you're audible.
My screen is visible, ma'am?
Yes.
Okay. Welcome all the doctors for today's very, very important program. And as you know, ma'am has covered pretty much what is old and what is totally new, and what are the different perspectives we need to keep in mind. So I'm going to talk about something which is very important and very relevant in today's times. The talk is titled as Maximizing Outcomes in PCOS Management. So when we look at the global prevalence of PCOS, what is one thing which is alarming or striking or very interesting is that overall the PCOS incidence seems to be coming down. And if I can put an average, it does not go beyond 6 to 8%. Maybe Australia is 26%, but in India, there is a wide variation of 10 to 40%. So that is how this PCOS is now becoming a existing epidemic in this country. Now, so what is a big deal? I found this very interesting study which looks at what is the obesity trends in men and women. And what is very interestingly are 3 pointers. Women generally, mind you, this is an Indian study, okay? And even though the sample size was small, what it correlates is a reflective pattern of today's people, that women have more obesity than men. In India, obesity is more common above the age of 25. And all of you will agree with me when I say that obese PCOS is more common than lean PCOS. Now, why does this problem happen? So this picture is very, very reflective of today's times. So we all know the 3 monkeys of Mahatma Gandhi, but today's younger generation is completely hooked on to the mobile phone. So what are the prospects of someone not leading a sedentary life, exercising, and then following a diet? This is central reason why Southeast Asians, especially Indians, are more prone to the gamut of diseases associated with obesity and metabolic syndrome. Now, we all know the etiopathogenesis of PCOS. I will not get into this. Ma'am has very eloquently covered this. But suffice to say that we already know genetics, we already know lifestyle, we already know hyperandrogenism, we already know insulin resistance. But today there is something very, very new and very interesting just come out. Research points out from the past 6 years that a low-grade inflammation actually connects all these pathogenic fulcrums of PCOS. Very important is that there is considerable debate on what exactly constitutes a polycystic ovarian syndrome. 2 important biochemical features are present in a vast majority of women. One is insulin resistance, the second one is chronic low-grade inflammation. Now, we all know insulin resistance. It is covered in every conference. About 70 to 80% of obese women have this insulin resistance. The common myth is that lean PCO patients do not have insulin resistance, but the studies point out that 20 to 30% of even lean PCOS actually have insulin resistance. Insulin resistance is the central fulcrum around which PCOS revolves. Now, to give you a very simple example of how this works, now imagine we are all in lockdown. We cannot go out to get the food, okay? And the door is locked. So there is a delivery boy who gets the food, and if there's nobody at the door to open the food cannot come inside. Now, this is exactly what happens in diabetes. The door I'm talking about is the house is the cell, the door is the receptor, and the doorkeeper is insulin. So type 1 diabetes, what happens? There is no insulin, there is nobody to open the door, the sugar cannot get inside this, and that is why we get all the problems associated with diabetes. In type 2 diabetes, what happens? Insulin is there, but insulin is old, insulin is obsolete. That is exactly what happens in polycystic ovarian disease. You need that glucose to enter the ovary for all the mechanisms it is there. When there is hyperinsulinemia, this does not happen. When there is obesity, there is increase in peripheral resistance and worsening of all these problems. Now, we all know that there is no single satisfactory treatment regimen for PCOS. Like ma'am mentioned, all the drugs are good, all the drugs are bad, all the drugs are ugly, but we still have to use them. What is very important to understand is that when we use OC pills for a longer time, we need to be cognizant of the cardiovascular side effects associated with OC pills. Now, this picture actually reminds us of looking at PCOS diagnosis. When PCOS patient comes to us, we don't know what exactly is happening. We do a lot of things. Somebody tells it's a rope, somebody tells it's a wall, but we have to address the elephant in the room. The pathogenesis of PCOS is very, very important to understand, and the evolution of that also is very, very important. The next question we need to ask is, today if you see, as per the Human Genomic Project study, the amount of bacteria in the body actually are 10 times more than the human cells. So what we need to wonder is, does polycystic ovarian disease start in the gut? So let me try to answer a few of these questions. Now, what are the key pathophysiological links? This theory is called as the dogma theory or dysbiosis of gut microbiota theory. Now, today what we know is that the diet, what we eat today, is not like what we ate 70 years before. It is a diet which is rich in saturated fatty acids and refined sugars. So what? These actually favor the growth of bad gram-negative bacteria in the gut, thereby reducing the growth of beneficial good bacteria like bifidobacterium and lactobacillus. Now, when these gram-negative bacteria take over the gut, what they do is that they disrupt this mucus layer, they hamper the absorption of key micronutrients. Unfortunately, the cell wall of this gram-negative bacteria also release a very powerful immunostimulant called as lipopolysaccharide. Now, this lipopolysaccharide causes a profound activation of the innate immunity because of this TNF-alpha and the interleukins. What happens? They go through the gut wall and enter the systemic circulation. So what? So what is going to happen? Evidence for microbiological dysbiosis under leaky gut. So this is a very interesting picture. On the left side, you have the gut or the intestine of somebody who's totally normal. As you see, you have the cells which are there, intestinal cells. They're tightly bound. You have a layer of mucus over them, and they're rich in the gram-positive bacteria. On the left side, what happens is the tight junctions of the cells are altered. The gaps are increasing. The mucus layer is lost, and these gram-negative bacteria take over, causing something called as gut dysbiosis. As a result, this lipopolysaccharide gets into the body and triggers a low-grade chronic inflammation. So what is the big deal? Now, when you have a low-grade chronic inflammation, that starts or tends to worsen the insulin resistance which is already there. And as a result, it worsens the pathogenesis of PCOS in patients, Now, what I'm trying to say is that there is a very strong positive correlation between the metabolic endotoxemia and the markers of immune activation, which means gut permeability plus metabolic endotoxemia equals increase in BMI and increase in C-reactive protein. Now, all of us know that C-reactive protein is a direct measurement of the chronic low-grade inflammation. So what? We need scientific evidence to back it up. So as I was talking about, this beautiful paper published in 2017 in Frontiers in Microbiology talks about the dysbiosis of gut microbiota. So just to summarize what I'm trying to tell you is that increase in gut mucosal permeability, leads to release of lipopolysaccharide from gram-negative bacteria that enter the systemic circulation. Immune system gets activated, induction of chronic low-grade inflammation happens, interferes with the insulin receptor function, increases the already existing insulin resistance, thereby increasing the ovarian androgen production. Now, very important to understand that whether it is obesity, whether it is lifestyle, whether it is PCOS, at the center there is chronic low-grade inflammation. So that is now emerging as the cornerstone of the pathophysiology of PCOS. So we can probably say that PCOS is a pro-inflammatory state. Of course, we need scientific evidence, right? Without any scientific evidence, we can't say. So this interesting meta-analysis is a meta-analysis of 31 studies studied. So what they saw is that women with PCOS who have an elevated CRP, it is an independent risk factor, independent of obesity. And this finding corroborates the existing molecular evidence that chronic low-grade inflammation is the pathogenesis of PCOS. In fact, they found 3 times more of CRP compared to a non-PCO woman. What is the role of pro-inflammatory cytokines in PCOS? So even in lean PCOS, when you have a leaky gut, that would generate the TNF-alpha and interleukin-6. Both these TNF-alpha and interleukin-6 have been linked to the generation of insulin resistance, and gut microbiota would be capable of initiating a state of insulin resistance if this continues to happen. So when we look at PCOS management, apart from what ma'am presented, what else can we do? So you all must be having in your clinical practice women who are obese, having obesity more than 25 or more than 25 years of age. Everything is given, but nothing happens. Okay. So there is a new molecule that is getting researched extensively, and with a lot of evidence is emerging. It is alpha-lactalbumin. So what is this alpha-lactalbumin? Alpha-lactalbumin, the scientific name is stearoic acid. It is a very, very, very strong and very interesting molecule. So what it does is, when you give alpha-lactalbumin, it goes undigested to the intestine. What are the problems I said? Chronic low-grade inflammation. So it brings down the amount of inflammatory markers. So it reduces the chronic low-grade inflammation. The second thing is, it creates a favorable environment for the gram-positive bacteria to grow back. So you just imagine a garden, right? You have a tree, that is the bacteria. The surrounding environment, the manure, everything is this alpha-lactalbumin. Okay? So it creates a favorable environment for the gram-positive bacteria to grow back. It is an antimicrobial. It reduces the amount of gram-negative bacteria. Now, I said the cells are loosened, so the tight junctions are made tight again. It increases the amount of mucus in the gut. And very importantly, through the SGLT transporters, it increases the absorption of key micronutrients like myoinositol. Now, these are all very good theories to say. As a clinician, you need clinical evidence, right? So what happens is that sometimes, even when we use the maximum and the best recommended dose of myoinositol, which is 2 grams twice daily, still some of the patients do not respond. So what they did in this study, which was published in Current Drug Delivery 2018, they found out that if you add this alpha-lactalbumin to myoinositol and dechiroinositol, it improves the absorption of myoinositol. So you see the blue line, that is plain myoinositol. The pink line is with added alpha-lactalbumin. As I said, to corroborate the data, the absorption of myoinositol increased by almost 100%. The Cmax increased by 30%. Now, traditionally, there is, ma'am also spoke about myoinositol. So why is this myoinositol important to us? Now, as I can say, the myoinositol dechiroinositol exists in various ratios. So if you go back to the example of the door and the house, which I said, myoinositol probably is the handle of the door. It opens the door for the glucose to get inside. And it has a very, very important role in both the hormonal pathway as well as the insulin resistance, reducing the insulin resistance. Now, on the left side, you see, it is the ovary of somebody who is totally normal. The follicular fluid is rich in myoinositol. But on the right side, you see, this is the ovary of somebody who's got a moderate or a severe polycystic ovarian disease. and there's a 500-fold reduction in minoxidil. Now, what we need to keep in mind is that these kind of studies are very difficult to do, but doesn't mean it doesn't exist. The classical example is vitamin C, what do you call it, deficiency, where you give sweet lime and the scurvy arrests. Okay, so PCOD is a state of minoxidil deficiency. I spoke about clinical evidence. So this very interesting paper published in Journal of Ovarian Research done by Montanina Olivia et al. Looked at what is the effect of minoxidil plus alpha-lactalbumin in PCOS. So what they did, they took 37 anovulated women. They gave the maximum efficient dose of minoxidil, which is 2 grams twice daily. 62% of them ovulated, but 14 or 38% of the patients did not ovulate. So in them, they said, okay, let's try a combination of minoxidil plus alpha-lactalbumin. So after adding this, the total number of ovulation patients or patients who ovulated was very high, and it was 95%. How does it work on the hormonal profile? So what they found is that there was a tremendous reduction in the testosterone, almost 35%, reduction in DHEA, which was 47%, and increase in SHBG, that was 92%. Now, we all must be using minoxidil, right? There are very, very important criteria to remember to get the best benefit out of minoxidil and decarbonicidil. One is BMI. If the BMI is below 25, plain minoxidil is very efficient. If the BMI is more than 25, decarbonicidil needs to be added, and because the peripheral resistance is very high. If the obesity is high, more than 25, if the age is more than 25, alpha-lactalbumin is very beneficial. Minoxidil is best effective when it is given 2 grams twice daily. The ratio of MI-DCI should be 40:1. Patient compliance is very, very important. And the last but not the least, whether it should be given in powder or tablets. So this particular study, if you see, very interestingly looked at, being a pharmacologist, I can tell you that these kind of studies are very, very interesting to do. You see the red line, they gave 4 grams once a day, and they found that it reaches a very high peak, but it falls down in the body after 12 hours. It means you need to repeat the dose. The same thing when it is given as 2 grams twice daily, the effect is sustained for 24 hours. And most of the other dosages like 1.1 or 550 are subtherapeutic. So what the author concludes is that 2 grams twice daily is the best and most efficient way to give minoxidil. And when you give it in a micro ionized granulation powder formulation, there is 100% bioavailability. So to give a better example, we all know vaccines. Can we make vaccines into tablets? Not possible, because it has a structure. We all know insulin. Many people try to get an oral formulation. Can we make insulin into a tablet? Not possible. Likewise, minoxidil is a biological substance. It has a stereoisomeric structure. It has to be given as a powder formulation. Recently, a very, I would say, consensus has been published as late as 2020, and this is an expert opinion view on inositols in the treatment of PCOS and non-insulin dependent diabetes. Okay, what they say is that minoxidil and decarbonicidil are effective in the treatment of PCOS. I'm not focusing on diabetes. The combination of MI plus alpha-lactalbumin was found to increase the intestinal absorption and therapeutic effects of minoxidil, and several studies demonstrate that MI and alpha-lactalbumin are very safe at therapeutic doses, and the US FDA, says that it is in the FDA GRAS group. We need evidences. So what are the evidences? This is an international consensus. They say that there is very good clinical data of MI-DCI, but the evidences are strongest when they're used for in a dose of 2 grams twice daily. So if I can summarize what I was trying to present, there are a lot of theories about PCOS. The theories of PCOS are evolving. The new theory is gut dysbiosis, which is very, very important. There are a lot of therapeutic avenues, and alpha-lactalbumin is something which is a new therapeutic paradigm which addresses this problem. Thank you so much. Thank you, ma'am.
Thank you, Dr. Kiran.
Yes.
Yeah, we came to know that there is one more entity called as gut dysbiosis, which is also predisposing for polycystic ovarian syndrome. No. So maybe we are using myoinositol these days, maybe completely not an alternative to metformin. But as we are using these myoinostols in 4 grams per day, we are getting good results. I would say I have been using this, and maybe probably PCO patients are responding very well with the minimal side effects, you know.
Thank you, ma'am. Thank you for sharing your personal experience.
Yeah.
So I think we can go on to the Q&A, ma'am. Ma'am, the first question is from Dr. Durga. Ma'am, your opinion on the management of thin PCOS patients?
Thin PCO patients, see, the management depends on the age of the patient, whether the patient is an adolescent patient, and also the clinical borders, whether she wants only the regularization of her menstrual cycles or if she is hoping for any fertility treatments. So if she is an adolescent PCO, the patient, she is a thin patient, so maybe we can try the other options of giving her oral contraceptives or to regularize her menstrual cycles. But if the patient is a lean PCO with infertility problems, then maybe we can try and give her either oral ovulations or gonadotropins, depending upon her age and also her previous, if she is having any fertility treatments before coming to you, and also depending upon her previous response, you can just give her the management.
Thank you, ma'am. Ma'am, the next question is pertaining to the trigger. So the question is, does the antagonist trigger yield as many M2 oocytes as HCG? The ideal timing for OPU after agonist trigger and timing of dual trigger in poor responders.
Agonist trigger, yes, whenever the agonist trigger is given, so there is no difference in the quality of the oocytes when compared with an agonist trigger and also a HCG trigger. So both yield good M2 oocytes. So ideal timing for OPU after agonist trigger would be around 35 to 36 hours. I would say, and timing of dual trigger in poor responders. Timing is okay. Dual trigger is we give an agonist trigger, and also we give them apart, 4 hours apart maybe. So dual trigger and also GnRH agonist trigger is given.
Thank you, ma'am. Ma'am, the next one is a case situation, and it's from Dr. Shireen Parveen. So there is a 27-year-old infertility patient with no dominant follicles. Patient has been treated with letrozole and gonadotropins. Or would laparoscopic ovarian drilling be helpful if her AMH is 6?
Yes, she is a 27-year-old patient with, she's not having any, if she is not having any response with the letrozole and also gonadotropins, look into her BMI, if she is having a high BMI, and also if her, if you see more number of follicles, going for ovarian drilling would be helpful for these patients, or you can try only gonadotropin cycle also for these patients. Try a chronic low dose gonadotropin protocol. Try it for 1 or 2 cycles. If there is a development, monofollicular development, then there is no need to go for laparoscopic ovarian drilling. But if she is not responding to that gonadotropin only cycles also, then maybe we can go for an ovarian drilling for this patient.
Thank you, ma'am. Any more questions to ma'am, doctors, or myself? Ma'am, I had a couple of questions.
Yeah.
If you don't mind.
Okay.
Ma'am, actually, I recently came across some research, like you mentioned, the fetal origins of PCOS. There is a group called Dr. Baxter et al., who is doing a lot of research on this intrauterine environment and all these things. So I want to know from your experience, ma'am, how important is this intrauterine environment with a pre-existing mother and grandmother of PCOS?
See, it's we have many theories that are there regarding this, But there are some studies, as you have told, that intrauterine exposure to these maternal androgens, that is babies whose mothers are having PCOS, they may have a little higher chances of developing PCOS when they grow up in the adolescence or in the adulthood, than when compared to the babies whose mothers are not having PCOS. So this theory can be validated as of today, maybe.
Thank you, ma'am. Ma'am, you actually dwelled on exercise and diet management and how important they are, and first line being the first line. Recently, ma'am, I saw one publication from Dr. V. Mohan's center. So what they have done actually, ma'am, they've seen what is the obesity incidence from urban versus rural population. One, and second thing is they have seen that what is the amount of people who do the physical activity, which is minimum 150 minutes per week. So they found very interestingly that the people who are from the urban centers do not do this 150 minutes of physical activity, and they have more obesity than the rural setup. Your comments on this, ma'am?
See, whether it is urban or rural, maybe we living in the urban areas rather than maybe all these things, we are more leading a more sedentary life than people in the rural areas, where they are very active, they do their own work. Maybe that also contributes to a little of physical activity, but in the urban setup, maybe we are having more of sedentary life and more of junk food and all these things, maybe because of that. And we are not following a proper exercise pattern, as you have told. So there is no 150 minutes per week of exercise. We are not doing that. So all these factors may be leading to obesity, and also junk food is the most important factor that is now leading to obesity.
Thank you, ma'am. There is a request from Dr. Karthik for sharing the paper on gut disease. Surely, Dr. Karthik, I will mail it to you. So if there are no further questions, I think we can close this session. First of all, a big thanks for all the audience for logging in today evening for a very, very important and very interesting webinar. I would like to extend my thanks to ma'am, especially who actually agreed to be a speaker. So thank you so much, ma'am, on behalf of the audience as well as the Shield team. I know you always prepare a lot for your presentations. It is very interesting. At the same time, there's a very beautiful balance of clinical information as well as practical information. Thank you so much, ma'am.
Thank you so much. I hope that I didn't bore all of them. And I thank once again Shield and Dr. Kiran for this amazing webinar.
Thank you, ma'am.
Thank you.